Conventional penetrating keratoplasty has been giving excellent clinical results in graft survival. However, there is prolonged visual rehabilitation associated with this procedure, mainly due to astigmatism. And recently, a greater emphasis is being placed on the speed and extent of visual rehabilitation. Femtosecond laser has been introduced in corneal surgeries, and this has led to a paradigm shift in the way the surgeries are performed. And give accurate cuts in various corneal planes, and we can get different patterns of the corneal cuts. In our study, I'll be discussing the mushroom pattern penetrating keratoplasty. The objectives of our study: visualization, study the corneal wound healing, and assess the corneal endothelial loss post-surgery. It was a prospective interventional case study, and the size of the study population was 26 eyes. All patients were eligible for penetrating keratoplasty pathology decreasing the vision, and active inflammation were excluded. Preoperatively, we assessed the uncorrected and best corrected visual acuity, refraction, the anterior segment and fundus, intraocular pressure, corneal topography measured using pentacam, and endothelial cell count of the donor cornea. All patients underwent a femtosecond laser-assisted penetrating keratoplasty in the mushroom configuration using a 60 kHz femtosecond laser. The donor cornea preparation was as follows. The laser parameters were entered into the computer. The donor cornea, which was preserved in LK medium, was mounted on an artificial anterior chamber. Dogging was performed, and the laser was used to cut the cornea in the desired configuration. Similar steps were used for host corneal excision. However, a small change was the use of a suction ring for stabilization of the globe. The donor was then sutured to the host using 16 interrupted sutures of tenonylon. These are the laser parameters used, and as we can see here, the mushroom configuration gives a larger diameter anterior cut and a smaller diameter posterior cut. Post-operatively, all patients were treated with topical steroids, and selective suture removal was started after 6 months. The post-operative evaluation included all the preoperative parameters as well as study of corneal wound healing using anterior segment OCT. We studied a total of 26 eyes of 26 patients, and in all these patients, the indication for surgery was advanced keratoconus. We had a minimum follow-up of 1 year in all the patients, and 50% of our study group had a follow-up of up to 2 years. Age of our total patients were in the pediatric age group. As we can see in this graph, we see a statistically significant improvement in the uncorrected and best corrected visual acuity right at the first month post-operatively, which has remained stable throughout. And we can also see an improvement in the cylinder at the first month, which has remained stable up to 2 years of follow-up. Pentacam K readings also saw a significant decrease in the first month, which has remained stable up to 24 months. This is a case example where we can see the pentacam image of a patient preoperatively showing advanced keratoconus, and post-operatively we can see regular astigmatism at all months and early topographic stabilization as early as 3 months. The endothelial cell loss noted at 1 year was 30.91%. This is anterior segment OCT images at serial follow-ups where we can see the mushroom configuration of the graft and good graft host apposition and early wound healing and stabilization of the graft host junction right at the first month, which has been maintained up to 2 years. When we compared the OCT images of a manual keratoplasty patient with a flat patient at similar time intervals, we can see the difference in the graft host apposition and wound healing. This is a clinical photograph of a patient with advanced keratoconus and best corrected visual acuity of 636, who at 6 months has got an uncorrected visual acuity of 6.9 with a very minimal refractive error. We did not have any intraoperative complications. We noticed a raised IOP in 9 patients due to steroid response, and 1 patient had graft rejection at 3rd month. A similar study has been performed by Chamberlain et al., who studied the outcomes of flat versus conventional PKP. They noted better visual acuity and astigmatism in the flat group. We also have noticed better astigmatism in the PKP in our flat group compared to their PKP group, and the visual acuity at 12 months. Olsen-Ajay et al. Compared the outcomes of conventional manual PKP for keratoconus. In our study, we noticed a superior visual outcome of flat compared to conventional PKP, and we also noted an early post-operative improvement and stabilization of astigmatism. However, this difference in improved visual outcome may be due to the superior graft host apposition, stable graft contour, and less chance of slippage due to the stepped corneal incisions. The endothelial cell loss noted in our study at 1 year has been similar to previous studies. Mushroom graft is better in keratoconus because the larger diameter anterior cut ensures that the sutures are away from the visual axis, thus minimizing the suture-reduced astigmatism. As the endothelium is normal in keratoconus, we take a smaller diameter of the endothelium, thus theoretically reducing the chances of rejection due to the reduced antigenic load. And also, as discussed, there is a better graft host apposition due to the lamellar cut. The drawbacks of our study: we do not have a control group of manual keratoplasty patients and we do not have long-term outcomes. To conclude, mushroom flap is a safe procedure and it provides early visual rehabilitation, faster topographic stabilization, rapid and superior wound healing, and maintenance of a stable graft contour. Mushroom configuration is advantageous in corneal diseases like keratoconus. Thank you.